Going to talk about atopic dermatitis today, and thanks for having me again. And the goal of this talk today is the first part is to address some misconceptions that I've come to identify in several patients in both like interacting with primary care providers, but also with patients who come about primarily topical steroids that we use a lot in management of atopic dermatitis. And then to focus on, how do we overcome these kind of concerns about topical steroids, and what are some tips for approaching eczema management that will help minimize the need for topical steroids over time. So atopic dermatitis, the most common chronic skin disease in children. I always tell my patients this is very much a disease of childhood. About 50% of cases will be identified in the first year of life, and up to 95% by age 5. It tends to be most severe in the younger years of life and tends to get less severe over time. But kids don't all necessarily grow out of atopic dermatitis. And we also know that even when the atopic dermatitis gets better with time, kids who have a history of this are at risk of other forms of eczema, like allergic contact dermatitis or irritant dermatitis, hand dermatitis, etc. So feeling comfortable with eczema is something that's both important for primary care, but also for the families. And so kind of making sure everybody's on the same page is the goal of this talk. So we're going to start with some misconceptions or they're not necessarily wrong, but just maybe not fully understood correctly with use of topical steroids. So the first one is that I hear a lot is that topical steroids will bleach my skin or bleach my kid's skin. So topical steroids can cause hypopigmentation in the skin, but it's not very common. It usually requires quite a significant amount of topical steroid use. Usually we're talking at least mid-potency, if not more high potency steroids. And it tends to occur when you get to the point of seeing other side effects from topical steroid overuse, like atrophy. More commonly, what we see quickly with use of topical steroids for atopic dermatitis is the post-inflammatory hypopigmentation that occurs, and that's very common. And so understanding the difference between this is just a result of the inflammation that we have now cleared up, this was going to be there regardless, this is post-inflammatory hypopigmentation, versus this is a side effect of the treatment. And so recognizing that it's very safe and kind of educating families that you may see light spots, and that's from the eczema. And also the second point to make here is that both the hypopigmentation that's post-inflammatory from the eczema, as well as hypopigmentation from topical steroid use, are almost always reversible. Okay. Now, atrophy from topical steroid use is not, but the hypopigmentation is. And so I always want to educate families about that too, that we're not causing a permanent change regardless. Vast majority of the time, I mean, I've seen the hypopigmentation from a topical steroid only a handful of times. And so truly the vast majority of the light spots that patients are coming in concerned about are from their eczema. But regardless, I think letting them know that it can get better on its own, regardless of what the cause is, will hopefully be reassuring to them. And this is an example of the hypopigmentation that's associated with topical steroid overuse, but you can clearly see that there's atrophy. You see surface indentations, you see telangiectasias, that you can see those underlying dermal vessels much more easily. So this is typically the context that I will see hypopigmentation from topical steroid use. The next issue is the bigger one that I'm going to talk about, and this has been much more prevalent over the last several years, and this is this idea of topical steroid addiction or topical steroid withdrawal. Okay, so I kind of did a deep dive into what is the evidence actually about this. So this was first reported probably in the 1990s. And it had a very specific kind of feature to it. And it was primarily on the face. And these were, when it was first, the biggest case series that was reported in 1999 was basically use of topical steroids for eyelid dermatitis. And so these patients were either using over the counter or a prescribed topical agent, but then kept using it and using it. And so what they ended up getting was larger involvement of the face. They originally were just using it for a localized contact dermatitis, but then they started to develop more and more rash over the face. The rash had rosacea-like features, but also had some redness and scaling. And it just kind of got worse and worse. And initially it would clear, they would use the topical steroid, it would get better. And then as they continued to get these outbreaks, they kept having more frequent flares. And so they wouldn't have this time period in between that where they were clear. So it became more and more dependent on the topical steroid. That's something that we learn in dermatology residency. We always talk about minimizing use of topical steroids on the face only as much as you need them, recognizing that there's this thing called periorificial dermatitis or steroid rosacea that can happen. But then, about 10 years ago, it started to enter into social media. And so it became this whole idea that any use of topical steroids, right, could lead to this addiction and these terrible symptoms that would happen when you withdraw from them. So and since then, there's been a few other studies or more reports and series that look into it, but it's really somewhat hard to kind of define exactly what it is. But classically, it's this bright erythema with scaling and oozing, or also with papulopustules, right? Like this kind of diverse presentation. They tend to note that it extends beyond what the original dermatitis was. It's associated with pruritus, oftentimes burning, dysesthesia as well. And then they note that it can be associated with more non-cutaneous symptoms such as sleep disturbance or even mood disturbance. So most of the cases are in adults, as I mentioned. Most of them were use of topical steroids on the face. And oftentimes, outside of that original kind of case series of using it for a contact dermatitis, the more recent reports of these, they were used for skin lightening. So there's a steroid in a compounded cream that people use for cosmetic purposes, or used for acne, right? Which are both things that, medically indicated we don't really use topical steroids for acne. So that was probably inappropriate use. And for the cosmetic, the lightening component of it, that has a very specific regimen that should be prescribed. But kind of this overuse in an inappropriate area. And almost always these happen with medium to high potency topical steroids, usually had onset within a few weeks, usually within a few days of steroid cessation. And so the management for topical steroid withdrawal in these two kind of systematic reviews of what was in the literature was to use steroid sparing agents, antihistamines, emollients, avoiding triggers or irritants like the sun, treating the acneiform or rosacea-like eruption with antibiotics, and then occasionally the need for addressing the mood disturbance associated with it. So what about in kids? So in those case series mentioned, or in those systematic reviews mentioned in the last slide, there were about 7% of the patients reported there were actually kids. So we don't have a ton of data about it. And then, in kind of looking for where are more examples of kids, that there's this one case series of about 10 pediatric patients with atopic dermatitis out of Australia that unfortunately is quite problematic. Because when you look at the actual information of these cases, you can't really find any sort of pattern, right? The topical steroid strength that was used, the locations that it was used varied, the length of time and frequency that it was used varied, and then they attributed steroid withdrawal to the steroids when it happened a few days afterward, up to 5 months after the last exposure to topical steroids. So really hard to kind of make that cause and effect association there strongly. The skin changes that they mentioned were very suggestive of uncontrolled atopic dermatitis. So hard to, again, necessarily say, is this because they pulled off it's technically steroid withdrawal, or because they just stopped their steroid and now their atopic dermatitis is out of control. And then some of the complications that they mentioned in this paper are known comorbidities of atopic dermatitis, like asthma. And so again, when you look in the literature, you really have to assess what's out there appropriately and really looking at, can we truly make these associations? Another thing that I wanted to mention is that out of these 10 cases, 7 of them had a reported known contact that had topical steroid withdrawal or had read about it in terms of the reason why they stopped their steroid, which obviously introduces a little bit of bias. And we know that that's usually why patients come in. I mean, patients come in having read about it and they're concerned about this in terms of wanting, oftentimes will say, I don't want to use any topical steroids because of this. And this is an example, this is the photo that they provided of this quote unquote red sleeve erythema, which looks a lot like uncontrolled atopic dermatitis. Now, I'm not saying that this isn't something that does not happen, but we have, there's not a great, there's not a lot of evidence that explains exactly what this is, how to exactly define it, and particularly in kids who, almost all the kids who are using these topical steroids have atopic dermatitis, which we know is going to fluctuate and going to, based on exposures or climate change, et cetera, may affect different areas at different times. All right, so let's kind of move on from some of the concerns that we have to just let's see, what do we know about topical corticosteroids? So the first use of topical corticosteroids for skin disease was in 1951, and all topical corticosteroids have this kind of basic 4-ring structure that they have, there's been multiple different iterations of it that now we have, dozens and dozens of topical corticosteroids that have varying strengths. And so we have all of these, options on the market now to utilize, and they have different strengths, different half-lives. They come in different vehicles. So they're very much, an integral part of management of skin inflammatory disease, including atopic dermatitis. Just as a reminder, topical corticosteroids, when you apply them, what gets absorbed into the skin, which is only a fraction of what gets put on because a lot of it gets rubbed off. But what gets absorbed into the skin then goes, they translocate all the way into the nucleus, and then they affect transcription of particular genes that control inflammatory cytokines. So how do we grade topical steroids? They're graded in classes from 1 to 7. Class 1 is our super potent topical steroids to 7, which is the minimally potent topical steroids. And so here's, this is a very common list of topical steroids that we use, like betamethasone, dipropionate, clobetasol, and halobetazol are kind of our 3 super potents that we have in the United States. Then, you kind of move down to more commonly used ones like mometasone, triamcinolone 0.1, which are kind of in our medium high categories. Then we have our medium low categories, which is our lower potency triamcinolones, and then our very low potency ones, which is like your hydrocortisones. Just so that you know, vehicle, meaning ointment as compared to cream, may move it a class. So the same medication, same name, same strength, same concentration, but in an ointment, oftentimes we'll move it up a class, meaning making it stronger and instead of prescribing the cream. So you're not, when you switch between those two, you're not actually switching apples to apples, okay? So what adverse effects do we want to, what do we know? We have a lot of good evidence about these, and what do we want to be counseling patients on? Well, this first one is this periorificial or steroid acne, steroid rosacea type eruption that we know happens when you have extended exposure to topical steroid on the face. Not everybody's going to get this, but if you truly use steroids over and over and over on a daily basis, this can happen. And we tend to see it initially happen in a periorificial location, so kind of coalescing around the mouth, the nose, the eyes. You get these kind of monomorphic pink papules. You might have some background erythema, some scaling, some crusting, as you can see in this picture. When you see this come in, whether or not they have a history of exposure to steroids, to topical steroids, you don't want to treat it with a steroid. That's the key. Because it will make it better initially, but again, it will keep coming back every time they come off the topical steroid. So, and in this patient, I would, assume, I'm not, sorry, I shouldn't say assume, but it's probably highly likely that this patient, maybe she has asthma and she uses an inhaled steroid, and maybe with a spacer. And so I see this a lot where it kind of starts around the mouth because inhaled, topical, or even systemic steroids can all trigger this rash. Atrophy. Atrophy is a big one that I always counsel about. I do see this in kids with atopic dermatitis in those hot spot areas where they've just continued to apply steroid even when they're doing fine and they just keep doing it every day. And so you get this thinning of the skin. Topical corticosteroids can decrease cell proliferation. They can also decrease collagen synthesis. And so you get this kind of really light, translucent appearing skin. You see those vessels underneath. Associated with that atrophy is you can also get striae, which start out as bright red, kind of linear atrophic plaques, and then those eventually kind of they shrink inward, or they become much thinner and hypopigmented over time. But both atrophy and striae are irreversible, and so it's important to talk about those and try and minimize those, because once they happen, we can't really turn those around. Topical corticosteroids, when used on top of certain infections like Candida, tinea, or HSV, can actually exacerbate those infections. And so here's an uncontrolled case of tinea. Notable but rare side effects, it's particularly in kids, as we talk about the suppression of the hypothalamic pituitary adrenal axis. And so, this is another one that I wanted to kind of give you some data on, because it's also somewhat vague. We don't have a great specific, like, you use this much of this particular topical steroid, it will suppress the axis, right? And so sometimes, it might be happening unbeknownst to us, because most of the time in these studies where they showed some HPA axis suppression, patients were asymptomatic. And so, in this one kind of, larger study, it showed that, first of all, it happens more so with high potency topical steroids, obviously, with bigger body surface area, right? And with occlusion, which improves that, right? That keeps it from rubbing off. So you're getting more absorption of what you're putting on. And so it ranged from like 1% risk with low potency topical steroids up to about 6% risk with high percent topical corticosteroids. And these were kids who were applying it daily, at least 2 to 4 weeks, to up to about 60% of their body surface area. And so this is, pretty considerable amount of area that they're applying topical steroid to. And so, again, when we think about appropriate use of topical steroids, we certainly want to make sure that we're only using it where it needs to go. And then again, remembering that, I don't think I ever tell someone that they can use it for 4 weeks total, right? And so setting specific timelines for their use. Also, just to mention ocular toxicity, that's why we don't use it around the eyes. It's with very controlled use. You can use small amounts of topical steroid at the beginning, but that is a location that you really want to quickly get off of the topical steroid and use something else. And this chart is, again, just kind of explaining or showing where absorption can vary depending on the body surface that you're putting it on. And so recognizing that you're more at risk of those side effects, particularly atrophy, or in the localized area like the eye, you're much more likely of those side effects in thin-skinned areas as compared to thicker-skinned areas like the hands and the feet. All right, so let's move away from kind of what are our risks to how do we avoid these? How do we safely use topical steroids, and what are some options outside of topical steroids? So first of all, I think it's important to remember that atopic dermatitis is chronic, right? So giving a 1 or 2 week course of a topical steroid is not going to, it very much only helps in the short term. You have to, set the expectations at the beginning with families that this is something that we're going to have to address over time. And we need to have a plan for a long-term and a maintenance plan rather than just, you have a flare, here's 7 days of a steroid. Okay, let me know, or, I'll see you next year. I also think, it's important. I always tell families there's no cure for atopic dermatitis, right? So it always is about controlling it. Okay. And while most patients are going to get a lot better over time, sometimes this is going to be, throughout their life that we're going to have a plan for how to manage this. And sorry, this is a duplicate of what I just said. And we already talked about how, again, even if it's not the atopic dermatitis, there's other forms of eczema that will happen over time. When you are giving topical steroids, I find that, it's very important to be specific. Families get confused very easily. I mean, I spend a ton of time with my eczema patients, and yet even when I'll bring them back, in a month, and there will have been confusion as to what they were supposed to do. I'll have explained it, I'll write it out. So, the more specific, the more times you can give that information to them, the easier they're going to find it. Okay. Typically I have a plan for flare and then a plan for maintenance. And so I'll say, when you're flaring, when you have an area that's really red and scaly and inflamed and itchy, this is what you do. And then when the skin is looking good, this is what you do. I think it's really helpful to write out each medication that you're prescribing and what it is. So, and part of it is going to be, use triamcinolone 0.025% ointment for 7 days, for the arms, for the rash that's on the arms. But also write out triamcinolone is a steroid. Okay. Because oftentimes you're giving them a steroid, a non-steroid, you might be giving them mupirocin, right, which is a topical antibiotic. And so explain to them what each one is. I will give them specific periods of time, like use this for 7 days, or use this for 10 days, or use it for 5 days. Because I think, it is also helpful to give them guidelines as to, we want this to improve, we want this to look better, we want it to clear up. But sometimes kind of gauging, like, I think this will take 1 week for this to get better. They're going to more easily follow that instruction than just saying, use it until it looks better, or use it when it flares and don't use it when it's not flaring. It's hard for parents sometimes to kind of make that decision on their own. So I tend to do a pulse followed by a taper, kind of like you would use with systemic steroids. You might use, a higher dose for the beginning and then slowly come off of it. So I have them use it every day for a specific, like I mentioned, amount of days, and then cut back to Monday, Wednesday, Friday for a couple weeks. That's my taper, and then they come off of it. And then again, just kind of reinforcing that, the part of kind of making sure you're talking or reaching back out to families, making sure that they're actually doing what needs to be done, or how you utilizing it, how you have instructed them to do so, because a lot of times what we think we're telling them is not necessarily what they're interpreting or hearing from us. And so this is an example, and this will be in your handout, of kind of like how I would write it out. And again, you always want to make sure exactly you're putting where you want to put it, because, where you want them to apply it to the body, because you're not going to put the same topical steroid on the face and diaper area or the axilla as you are going to be on the trunk, arms, and legs. This is a really helpful thing. How much steroid do we use? Well, there's the thing called a fingertip unit, and this is in your handout, and you can go to this website. That there's a lot of websites out there that'll kind of give you information on a fingertip unit. So this kind of tells you how much do they need to put on. So if you've got an infant and they've got eczema all over their arm, I mean, usually it's not all over the arm, but let's say it is, you're going to use 1 adult fingertip unit of medication on that. That should be enough to cover the area. Okay, so this kind of gives them some specific ideas of like how much topical steroid do they need to use, because sometimes they're under or overutilizing it, right? They're gooping it on, or they're using this tiny amount and they're really not getting the, the actual efficacy that we want. And so this is going to vary based on the age of the patient, right? Because kids grow. And so they have this particular website has it kind of for these different age delineations. And this can also be helpful in kind of trying to get an idea of how much steroid do I need to prescribe for these patients, right? So 1 fingertip is about 1/2 gram. And so you kind of get an idea, you do some math, you get an idea of how many fingertip units you think they're going to need over the course of a month, and then divide that in half, multiply that by 2, and then you kind of have how many grams. Okay. Always emphasize dry skincare routine, right? So now we've kind of talked about, how do we prescribe topical steroids? How do we use topical steroids effectively and safely? So what are other ways that we need to manage atopic dermatitis? not utilizing topical steroids. So one is always explaining that, it's not just about the medication, right? It's also about the skin barrier, and medication is going to do nothing about the skin barrier. The skin barrier is still defective in kids with atopic dermatitis. They're still getting dry. They're still being, they're still absorbing particles that cause inflammation. The proteins in their skin are not fully, they don't function completely appropriately. They're still prone to secondary infections, all because of the atopic dermatitis. And so that really, we address that with the skincare routine. And so what I recommend is bathing daily or every other day. Again, this is going to be in your handout. Lukewarm water, no more than 10 minutes. I don't recommend bathing once a week or twice a week because I find that getting in the water is actually a good source of hydration for the skin. Now, if you overdo it or you soap up like crazy, okay, now we're going to move the other direction. But actually just exposure to plain water, which is the main goal of bathing in kids with atopic dermatitis, that's going to be a nice source of hydration. If you're going to use soap, again, oftentimes I'm not using soap at all in kids with eczema, just having them sit in the water. You want to use one that's just some general recommendations about soaps. Bar soaps are better than body wash. They have less chemicals in them, or they have less of those additive agents that can irritate the skin. Non-soap cleansers are going to have less of an effect on the pH, which can exacerbate atopic dermatitis as well. And then you only want to use soap on areas that truly need it, which in babies is their bottoms, right? And as the kids get older, armpits, groin, buttock, and feet. That's where we really focus soap on and leave everything else alone. Rules about applying a moisturizer. Moisturizer is kind of a misnomer. We call them emollients, but of course, patients aren't necessarily familiar with that term. My rule of thumb is it comes in a jar. You have to scoop it out. That'll mean it's thick enough. There's a lot of variety in that. And then you put it on within 2 minutes of getting out of the water. All right. And you all, the rest of that you can kind of use in your handout. This should be my tip 3A instead of its own tip. Petroleum jellies are really great. Emollient, there was this nice, kind of historical review paper of petroleum jelly, how we got it, and, what are the papers that are out there. It's just great. It has the least amount of other agents in it. It's really effective. It has the highest oil content of any of the emollients out there. And so it's safe, it's cheap, it's effective. So, that's, if there's any, concern about getting an emollient, this is always a good option for you. And this was a nice paper that kind of reinforced how effective it is and why we love it so much. All right, the last tip here is just to touch on what are our non-steroid options, right? We've used steroids for 70 years, but over the last 20 years, right, we've come out with some other options so that we don't have to rely on steroids so much. So our big, categories in terms of topicals are calcineurin inhibitors, which is your pimecrolimus or tacrolimus, phosphodiesterase 4 inhibitors, which is crisaborole. There's another one that's approved for psoriasis, but not for atopic dermatitis. We have a Janus kinase inhibitor that's approved for atopic dermatitis, ruxolitinib 1.5% cream, which is only approved in 12 and older. And now there's pending an FDA approval for use in atopic dermatitis in kids 2 and older of tapinarof cream, which has this really unique mechanism of action and has been pretty darn effective in patients with psoriasis. And so we're pretty hopeful once we get this approval of how helpful it can be. So how do we use these? You could use them as a replacement for a topical steroid. Usually, these are going to replace low potency topical steroids. So it's going to have to be pretty mild eczema for these to be effective as a replacement. But more oftentimes what I utilize them for is as more of a maintenance regimen, right? Use these longer term when things are doing well in very, in small bursts or in small amounts, so that you can prolong your periods between need for topical steroids, because topical steroids come in very effective, very strong, they come in different strengths, right? So oftentimes you're going to get more efficacy with your topical steroids. So we use those for flares. And then the in-between time, sometimes we can make that extend longer by utilizing these non-steroid alternatives. And so this is an example of whether just doing a topical steroid for flare and then coming off and just doing skincare in between, and you keep having to using these high bursts of topical steroids versus clearing up the flare, but then using a calcineurin inhibitor, a couple times a week. And what you find is that those flares end up not being as severe. And so you don't have to use as much topical steroid, if at all. They've, in this particular approach, they even just increased use of the topical calcineurin inhibitor for increased activity. And then another one, which is crisaborole ointment. And I kind of focused on those two because they're the ones that are approved right now for young children. This was actually out of like the last year, I think 2023, yeah, where they basically looked at using it every day for maintenance. And they found that, up to a year it was safe. And the kids who are using it every day had decreased flares and longer times in between their flares. And so that's another option. And so if you go back to this kind of, what are the instructions that you're going to give the patient? You do the pulse for what you think is going to clear the flare. Then you do the taper, so Monday, Wednesday, Friday for a couple weeks. And then you give them their maintenance plan, which is going to be primarily the non-steroid use for however many days you feel like they need it per week in between, even though their skin is looking good. And oftentimes that will significantly decrease the need for topical steroids. Okay, so just as a review of what we went over today, feeling comfortable with topical corticosteroids. Hopefully this has been helpful and kind of enlightened about, what is the data behind some of these risks that seem to be very prevalent in parents' minds, but so that you can educate them appropriately on this. Recognizing that they do have some side effects, right? We want to be aware of that. We want to use them safely, but we want to really understand what is the data behind those side effects. And then, again, approaching atopic dermatitis as a chronic process, setting that expectation up at the forefront so that parents understand, that this is going to require medication over time. There is no cure. We're not just going to clear it up. There's not one thing that they're doing that's causing it. And so sometimes that will help with understanding appropriate use of medications, following instructions appropriately, understanding what the long-term goal is. Trying to be as specific as possible, again, with those instructions, checking in frequently, and then, again, kind of giving you some other ideas for how we implement those non-steroid agents for atopic dermatitis and how they can help with decreasing use of topical steroids. All right, and thanks so much. I'll stop sharing.
All right, thank you, Dr. Todd. So can you reiterate how many times you would, per week, you would use the steroid sparing ointments?
Yeah, it kind of depends on which one you're using. So with the crisaborole, with that recent study, they were using it once a day, every day. And with the calcineurin inhibitors, again, that particular paper was using it 2 times a week. And frequently I'll have them, yes, or even 3 times a week, Monday, Wednesday, Friday, oftentimes when they're tapering. So say they'll have a flare, they tend to be, popliteal anticubital faucet. So I'll have them use triamcinolone 0.1% ointment, 7 to 10 days, and then go to Monday, Wednesday, Friday. And I'll have them start to incorporate tacrolimus Tuesday, Thursday, Saturday, Sunday, right? So they're kind of going every other day, switching between them. Then they stop the steroid, but continue the non-steroid every other day to those areas. And that's kind of how I'll transition them.
Okay. And how would you treat eyelid atopic dermatitis if it is severe?
Yeah. So what I personally do is I will give them like hydrocortisone 2.5% ointment and let them use that for 3 days, twice a day. And, we talk about, you're not applying it to the eye, you're applying it to the eyelid, but I'll let them use it for about 3 days to calm that down. And then I transition to pimecrolimus or tacrolimus. What I find is that the biggest side effect with these non-steroid agents is burning of the skin. And it can be pretty significant, and parents will not use it. And I've used tacrolimus on my eyelids before, and it does sting. It does stop after 1 to 2 minutes, but in a kid, it's hard to explain that to them. But if you use the steroid for just a few days, it calms that inflammation down. I think it kind of closes up any openings, and so it makes that non-steroid a little bit more tolerable. Now, that's what I do. I'm not saying, again, ophthalmologists out there might be like, don't ever use a topical steroid on the eyelid. But I haven't had any issues with using it that way. I give them 3 days.
Okay. And do you find that referral or concurrent management with an allergist can help, especially if it's part of the allergy, asthma, atopic derm triad?
I I mean, personally, and this is my bias, I mean, I find that, atopic dermatitis, well, hopefully a lot of mild disease, right, can be managed in the primary care setting and doesn't need a specialist, right? I mean, we're happy to help, but knowing limited access, kind of reserving those more real severe cases that you're out of your comfort zone with the level of topical steroid that you're using and we're still not controlled, or sometimes there's a concomitant contact dermatitis, right? It's just not behaving appropriately. That's definitely where we're at. I find, I prefer to manage the atopic dermatitis if they have comorbidities, absolutely. And not, obviously, our allergists, I work with our allergists all the time and they're super helpful. And I find that we have different levels of comfort within the atopic triad. And so, but I don't know that managing one necessarily keeps the other ones. I think there's just different approaches and one can be totally out of control and the other ones can be doing fine. So it kind of just is a case by case basis.
Okay. And would you recommend vitamin E oil as an adjunct for atopic derm, especially for families that would prefer to not use topical steroids?
I don't know any significant data that vitamin E has any sort of level of efficacy. If they're really hesitant about topical steroids, I do think it's important, then I would send those patients to dermatology, just because we're really comfortable we have like all of these other agents that we might utilize, and can give them a few more options, or can hopefully maybe get them more on board with use of topical steroids, just because we use them all the time and they might feel more comfortable with someone who's been using them on babies and, and saying, look, your kid's going to be fine.
And one question off atopic dermatitis. How do you feel about the commonly prescribed magic butt paste for diaper rashes?
No, I think it's fine. Occasionally, I was actually thinking about this because I have I have a 6-week-old and he fortunately doesn't have a diaper rash. But what is it? What is it that some of these kids have just such severe irritant diaper dermatitis, right? What is it exactly that's triggering it in these kids? So no, I mean, I think that the majority of kids get better with that. Because I have the kids who come in with really terrible, disease that, yeah, they'll have tried most diaper creams. But I haven't had anybody who's had like a true issue with it. So yeah, I'm fine with that.
Okay, and one last one. What are the qualifications for Dupixent?
Yeah.
D-U-P-I-X, yeah.
Yeah, dupilumab. So, yeah, and I didn't really touch, I tried to say with topicals because once we're getting into the realm of like needing systemic agents, it's probably going to be something that a dermatologist should be managing at this point. I don't know, dupilumab may, be something that primary care providers prescribe, but, at this point it's still fairly new. It's a systemic agent. And so, it is approved for 6 months and older in patients with moderate to severe atopic dermatitis. And it's incredibly effective. I really like dupilumab. It's pretty safe. It doesn't affect, risk of bacterial or viral infections or, systemic infections. So it's not like our biologics that we utilize for psoriasis, right? Which block, TNF alpha. So really the main thing that it would affect in terms of like infection is a parasite. But fortunately we don't get exposed to those too much here. So for kids who need that, I use it. I use it
Okay.
quite a bit.
Well, thank you so much. We're going to have to stop here, but thank you, Dr. Todd.